name is Min. I'm one of the orthopaedic registrars. Today I'm going to be presenting on mechanical complications following intramedullary fixation of extracapsular hip fractures. I'd like to acknowledge the traditional owners of the land on which we work and learn, and pay our respects to their elders, past, present and emerging. Proximal femur fractures are the second most common fracture configuration in the world. They account for 15% of all fractures. Conservative estimates predict that numbers could reach 21 million annually by 2050. They come second to distal radius fractures. They have a bimodal distribution affecting the young and the elderly, and largely speaking, they can be divided into two categories: intracapsular and extracapsular. Extracapsular neck and femur fractures occur distal to the hip joint capsule, and this means that the blood supply to the fracture site is adequate and therefore enables fracture healing. In these fractures, internal fixation is a viable method of operative fixation. There are two different implants that we use for internal fixation, and these include a DHS or an intramedullary nail. With the intramedullary nail, you can use a single lag screw or a dual lag screw. These two internal fixation devices are pictured on the right. In terms of the pathoanatomy, we have deforming forces on the proximal fragment, including abduction from glute medius and minimus, flexion from iliopsoas, and external rotation from the short external rotators. The deforming forces on the distal fragment include adduction and shortening from the adductors. There are several risk factors for mechanical complications, and these can be divided into host-specific, stability, implant choice, and surgical technique. Risk factors associated with the host include having osteoporotic bone. Osteoporosis diminishes bone quality, impairing primary screw purchase, which may lead to loosening and instability of fixation. Smoking is one of the most important modifiable patient risk factors, especially in the post-operative period. It's a well-recognised retardant for fracture healing because the deleterious action of nicotine acts through increasing vasoconstriction and platelet aggregation, leading to reduced healing. We know that diabetes is also a very important risk factor because it reduces cellularity at the fracture site, reduces callus strength, and in general, patients with diabetes require 1.6 times longer to heal compared to those without. Stability of a fracture refers to the ability of a fracture to resist further displacement, motion, and collapse after internal fixation. If we look at the stable type of fracture configurations, which are highlighted in red, we see that they share similar qualities, including intact cortex, intact lateral wall, which is at least 25 millimeters thick, intact posterior medial cortex, and no varus or procurvative displacement. Unstable fractures, which are now highlighted in red, show posterior medial as well as GT comminution. These fractures tend to collapse into varus. They have loss of a lateral wall, loss of the LT, and these have rotational instability, which makes them more likely to go on to fail following fixation. Surgical technique is very important, and it's a factor that we can have some sort of control over. It's very important to avoid iatrogenic varus malreduction prior to fixation. And certain techniques that can cause varus malreduction include having an entry point lateral to the GT tip, as well as eccentric reaming over the guide wire. Complications that we see in extracapsular neck and femur fracture fixation include cutout, proximal femoral shortening, non-union or delayed union, as well as early implant failure. In terms of cutout and loss of fixation, this is the most common complication, occurring in 2.3% of patients undergoing intramedullary or DHS fixation. Usually it occurs within the first 12 weeks. And surgical factors involved include malreduction in varus, a tip apex distance of greater than 20 millimeters, as well as an internal fixation with a single screw when doing intramedullary nailing versus dual screw. However, the large majority of our IM nails are done with a single screw. Down here we can see X-rays A and B representing immediate post-op X-rays following an IM nail of an extracapsular neck of femur fracture. The issues that we can see here include a tip apex distance of greater than 35 mm, superolateral location of the lag screw of the intramedullary nail tip, lateral entry point, and subsequent varus angulation with loss of the posterior medial cortex and contact. X-ray C and D taken at 1 month post-op demonstrate cutout of the lag screw through the femoral head and subsequent varus collapse. Proximal femoral shortening is another form of complication. It's a common sequelae after IM nail and DHS. It can be broken down into controlled or uncontrolled shortening. In terms of uncontrolled, this is defined by shortening of greater than 8 mils. It's usually rapid and excessive. Patients end up with a leg length discrepancy and loss of abductor tension, and they often go on to develop severe pain, limiting mobility. In terms of controlled, this is oftentimes desirable in our fixation. It achieves fracture union, is less than 8 mils, and the requirements for this is having maximal cortical contact with proximal dynamization. So the way that we try to achieve this is by unlocking the proximal set screw on an intramedullary nail a quarter turn to allow a degree of controlled collapse. Delayed and non-union rates are 7 to 20% for subtrochanteric NOFs, 6% for reverse oblique, and 1 to 2% for pertrox. Risk factors for non-union include varus malalignment and lack of medial cortex contact. Implant fracture is very rare. It's defined as failure of the implant within 4 months. It's due to repeated loading in the absence of healing. It can relate to implant notching, it can relate to insertion technique or guide wire or anti-rotational wire placement, as well as cerclage wires at the level of the fracture. Autodynamization can also occur through approximately 3 months post-op. And with this, you generally tend to find that one of the distal cross bolts breaks. It usually predates proximal implant breakage by approximately 2 months, and it indicates a degree of mechanical instability. And in these cases, early revision is oftentimes recommended, but should be considered on a case-by-case basis. So, implant choice for stable fractures, DHS or IM nail both are appropriate, but for complex fractures, should we use a DHS or an intramedullary nail? And if we use an intramedullary nail, should we use a single or a dual lag screw? This was an article, a systematic review and meta-analysis published in 2021, which demonstrated that comparing DHSs versus intramedullary nail, there was no difference in terms of operative time and blood. There was a difference in terms of operative time and blood loss in favour of intramedullary nailing. However, there was no significant difference in the post-operative outcomes between the two. And in addition to this, we know that intramedullary nails on average cost more than a DHS. So that's also worth considering. So, in terms of management, salvage osteosynthesis and conversion hip arthroplasty remain the mainstays of treatment for failed internal fixation of extracapsular fractures rather than conservative or non-operative management, which is very much limited to infirm patients. Arthroplasty is not straightforward. There's oftentimes poor proximal bone stock from your previous surgery, There may be abductor deficiency from damage to the GT, from fracture, as well as instrumentation. However, revision to arthroplasty would enable early weight bearing, which is particularly important in this patient population, and we do not have to rely on achieving union to improve mobility. In general, hip arthroplasty is preferable for the geriatric population with poor bone quality, inadequate bone stock, and severely damaged hip articular surfaces, whereas salvage osteosynthesis is usually preferable for young patients with long life expectancies and adequate bone quality for fixation. So take-home messages is avoid varus reduction. Aside from certain fracture configurations, there's really no difference in terms of postoperative complications for intramedullary nail and DHS, and that for those who do have mechanical complications post-op, the decision for revision versus salvage is an individualised one. These are my references. Thanks very much for your time.